Hello, everyone. We are live. I was just saying it's hot in here because it's hot. It's hot. We've got some warm, delightful information with you today. My name is Bob Miglani. Welcome to our live stream. I'm super delighted to be with you today. We're going to share. This is for pharmaceutical executives in marketing, patient services, commercial operations, people who run hubs, brand managers. And I'm thrilled to have a super important, smart guest on our show today, Rajeswari Narayan. Rajeswari, how are you? Nice to see you.
See you too. Thank you for having me.
Of course. And we have Jason Grossman. Jason is a biopharma commercial executive. How are you, Jay?
I'm doing great, Bob.
Excellent. Nice to see you. So what we're going to talk about today is something really fascinating, which is what is the evolution of patient services and why some of the programs are failing. Not all of the programs are failing, but some of them are failing. And they're failing miserably. Millions are being spent. And so we have an expert here. Rajeswari Raj is going to explain to us and share some of her past experiences on how to build patient support programs that work really, really well. Rajeswari, welcome to the Patient Experience Podcast. I'd love for you to dive in. Tell us who you are. Tell us how you got here. Okay? So we want to know about you a little bit. So tell us about you a little bit.
Thank you. Thank you for having me, Bob, and super happy to be here. Hi, everyone. I'm Raj. I started off my career in pharma more than a decade and a half ago. I started off as a rep, actually, when I was a teenager in Buffalo. That's where I studied. I went to school at State University of New York, graduated in biological sciences and biochemistry. Thereafter, began my career at Merck at White House Station, New Jersey, where they were headquartered at the time. Then I moved on to working with Roche and Novartis. At Roche was where my career in patient support began, launching the Blue Tree patient support program for them for their entire oncology portfolio. And thereafter, I've worked with Astellas and Eli Lilly. Most recently, I've also worked at the vendor end here in Canada. So I've had a mix of both pharma as well as vendor end and patient support services. And I've been in the PSP space for over 12 years.
Wow.
Yeah.
That's amazing. So you've got a lot of good stories to share with us. We want stories. We want hot stories. We want juicy gossip. We want to know the inside. Okay. So we want to know everything. So thank you for that, right, Rajeswari. You've seen big pharma, you've seen little pharma, and everything in between.
Yeah.
So that's wonderful. Jason, tell us a little bit about you, please.
Sure. So I've been in the industry for 30 years, and like Raj, I started as a sales rep and worked my way up into different parts of the business. I've been in marketing, I've been in trade and channel, I've been in market access. I've been in generics, biosimilars. Most of my career is spent in oncology, and my last bunch of years has been in startup across oncology, hematology, cardiology, and it's been a very rewarding time. I've seen evolutions over the years. And the current evolution is in patients, and how do we activate them, and how do we get them on life-saving products, and then how do we keep them on? And there's 3 real-world issues that pharma has to deal with when they think about patients, and that's the financial aspect, that's the clinical aspect, and the emotional aspect. And what we're seeing now going across the digital opportunity versus the paper opportunity that we're evolving from allows greater information, better information, more informed information across not only the patients, but the caregivers, and the people that they interact with every day. So I'm excited to be here with Raj and to hear her stories.
Wonderful. Yeah, love that. Love that. Thank you, Jack. Thank you for that, Jason. And if you don't know me, my name is Bob Miglani. I spent a long time in pharma. I was at Pfizer for 23 years, corporate headquarters, from sales to pricing to market access, a number of other patient engagement. I left about 10 years ago, and I wrote some books and became a speaker. And today run Hoot, which is a digital patient education company that helps pharma increase revenues. And how do we increase revenues is really through patient education. But I want to talk to Rajeswari today. Let's zoom out for a second. Where is patient services evolving to? Where was it 10 years ago? Where is it now? And where's it going? Give us a sense of your 30,000 foot view of seeing patient services, the evolution, if you will, over the last, let's say, 10 years or 20 years and where it's headed.
Sure. Well, first, to zoom out a little bit further there, Bob, to go 50,000 foot, what was the original vision for patient support services? It was patient empowerment. It was to get patients started on therapy, taking down all the barriers and getting them staying on therapy to achieve the best possible patient outcomes.
Yeah.
So we've come a long way. 10 years ago, we were giving out, it was more of a bridging program. We were giving out free product. It was a card program and more. Right now, we're looking at a more of a holistic situation where we're tackling the clinical aspect of the patient journey, financial aspect. The reimbursement navigation still continues to be the core and bane of patient services. But we've come a long way from just giving out free medication and card programs. Where we are headed is patient empowerment. We're headed solidly towards that, geared towards that. And where the roadmap to that is currently, we have a very, very fragmented landscape. And how we're going to get to patient empowerment is basically the provision of patient services will be democratized. And I'll tell you how we'll get there, because right now the situation is so fragmented. And of course, rightfully so, many players are entering the market with different kinds of services providing to patients. The key players still happen to be the major suppliers, who somehow also happen to be the distributors. Go figure. Yeah, they're still the major players, but you're going to see a mass downscaling in terms of patient volumes to these new players who are already existing in the market. There was a friendly competition before, and now we're seeing some elevated temperatures, and soon it's going to be a mosh pit.
Yeah.
And that's going to push for a need of unified CRM, a CRM currently that unifies all the other CRM and draws data. And this CRM is something that even the patients would have access to. And that would basically democratize the provision of the services. And once that happens, patients will continue to be empowered to navigate the reimbursement landscape themselves.
Yeah.
And that is basically the core of the services which most patients would take on themselves. And that would leave room for the major players and other players to focus on the clinical aspect, digitization, providing patient materials, adherence reminders, risk stratification, and more. And then, of course, with the current market scenario, the economic landscape, we will see an increase in uptake of the financial services. So you can expect a movement. So now at the pharma end, when you look at your monthly program invoices, if you're looking at, say, around 80% of the costs being because of your headcount at the hub operations, you will soon see a descaling in that, because these other players are going to take over your patient volumes. Patient initiation and adherence is revenue. So it's going to be democratized all around.
Yeah.
And then there's going to be an increase in focus, the spending on the clinical side, digitizing the patient journey, providing them with the digital materials, tracking them, and more. And of course, there'll be an increase in the financial services, the expenses offered. So One hits your program budget, the other hits your P&L. So even though you'll see a decrease in the cost and services in the hub operations, it doesn't mean your overall expenses are going to decrease. It's just going to go from one direction to the other.
Yeah. So what you're saying, you've said a lot here, and it's a little overwhelming in some sense, because as a patient services leader, I see this future and I'm like, oh my God, it's overwhelming, it's exhausting, it's complex, it's really, really complicated because we're moving, as you said, from brochures and copay programs to this complete revamping of the system, driven, I think, largely by the patient, right? Patient demands, expectations, and efficiency of markets. Tell us, let's drill it down a little bit. I know you've talked to us before about 3 areas that you think patient service programs are find effectiveness. In my view is again, it's a bolder view here, is that some patient programs are failing flat on their face. Patient services are not innovating as much as they should and they could. And that's largely, could be a budget issue, could be, look, my boss is retiring, I don't want to rock the boat. I've seen that. Like, hey, don't do anything new because you might get laid off because, hey, my boss is leaving, so I don't want to mess anything up and wait for the new person to come in.
Yeah.
And so there's a little bit of that. So I know there's 3 things you want to talk about that really lead patient services managers to success. So talk about one of those things, if you don't mind. Talk to us about your strategies. You think patient service programs, what makes them work? Let's talk about that. What makes patient services work really, really well?
Okay, so if we're going to start off, let's start off with the single most biggest factor in the prescriber behavior that actually enables enrollment and the uptake of the PSPs. The single biggest driver for prescribing behavior is workflow efficiency, right? Workflow efficiency, it increases the clinical inertia, which makes the physician sigh and just give up. And therein comes in the EMR aspect. The EMRs play a critical role in providing access to the physician, the enrollment form access to the physician. That's the single biggest driver. EMR also provide convenience because provided you have the patient chart open, you can auto-populate that enrollment form. So instead of the enrollment form taking at least 10 to 20 minutes to fill out, it takes lesser than 2 minutes because of the features that the EMRs offer. So many companies currently, of course, EMRs don't come cheap. They're not cheap. It's a $90,000 fee to upload a single enrollment form across all EMRs in Canada. And there are many EMRs. I believe there are close to 60.
Wow. $90,000 for one EMR just off the gate to do an enrollment form in the EHI.
So $90,000 to upload in all EMRs.
All EMRs, okay.
All EMRs, Canada-wide, which have over a 70% physician coverage, as it's been marketed. But there is a different approach you can take instead of doing that. You can also do a phased approach, which is the worst strategy ever, and that is done because of budget reasons. Now, $90,000 can be a huge, amount to gulp, right? Upfront, and that's why many companies choose a phased approach, which is a very wrong strategy. Now, a phased approach is chosen by uploading with a cluster of EMRs or single EMRs that target your top prescribers. And that is a hit or miss because it's not a guarantee that your prescriber is using that particular cluster of EMRs. And prescribers move clinics all the time. So while they may have access to your enrollment form in one EMR, doesn't mean that they have access in the other EMRs. And these EMRs don't talk to each other, right? That's why you're being given the option of uploading a form in one EMR for 1/10 of the cost. So the cost is a main driver. So that's the worst strategy because the moment the physician cannot access the form in the EMR, the physician sighs, goes, that's it. and there goes your uptake.
Enrollment. Yeah. But let me ask you a question. Let me talk about this. This is something that I actually, we work with clinics across the country, and it is very frustrating to work with EMRs as a software company ourselves, right? And the reason is because there's some of them don't play well, and they don't integrate with any software. Then they charge you all these fees that are very, irrelevant in one sense. They're exorbitant. They're expensive. They're high. But again, also, there's a lot of burden on the doctor with EMR enrollment or the staff. So why not just take that away? Why not have a different way for the consumer, for the patient to enroll themselves with a QR code or something like that? Like, why can't we make it simpler and take that heavy burden off their plate?
That's a very good question. So if you want to remove EMRs altogether, there's a lot more that EMRs do than just, populating the enrollment form. There's other documentation there as well. Yeah. So I don't think getting rid of EMRs totally will ever be an option, at least not in the near future. Yeah. That's why I was suggesting the unified CRM, which would draw the data from all the EMRs and the patient charts, and everybody would have access to it. But that's not an option. There are additional functions that the EMRs offers, and we can get rid of them.
But EMRs, I mean, look, in the US, the gorilla in the room here, or the elephant in the room, is Epic, right? Epic has majority share, and they don't want to play well with anyone else. And then you've got hundreds and hundreds and hundreds of EMRs out there. So I totally understand the enrollment is really key, and understanding the friction the doctor has in the clinic. And I find that, in my conversation with some pharmaceutical executives, they're almost like, well, if you try to introduce something new, they're like, oh, you know what? I don't know. I don't know what's going to work. They almost become pessimistic about everything because they've seen it all, right? And this is one of the challenges I see is, but you're talking, let's go back into enrollment here for a second. So you found that if you have some sort of a unified, capability that, gets every doctor in, wherever in your program to have a simple way to enroll patients, it's really powerful. And I think I agree with that. I totally agree with that. The question becomes, isn't that normal? Registry aren't people already doing that, or they're not doing that? They're not doing this right now.
You mean to say a unified CRM?
Yeah.
We have some products in the market. Unfortunately, they've gained less than 4% traction.
Yeah.
So physician goes to the system that they're most familiar with, most comfortable with. So you can't put a price tag on that.
Yeah.
Familiarity, the convenience, the comfort levels, of course, and that still happens to be EMRs.
Yes, yeah. Jason, tell me what's in your experience been in terms of enrollment? What have you seen that works, whether it's digital or traditional? Talk about enrollment that Rajeswari has brought up as a very important driver of program initiation. Talk about enrollment a little bit.
Sure. Let's talk a little bit about in the U.S. how enrollment happens. Right. Typically it's through a hub, but hubs are evolving also. They're becoming digital hubs, alternative specialty light opportunities, where you're bringing distribution along with all the hub opportunities into one opportunity. And those vendors are actually becoming better and better at the three challenges that I mentioned up front: the emotional, the financial, and the clinical.
Yeah.
And depending on the disease state will depend on the age of the patient and our parents. Right. I know from my own experience, my parents are challenged with technology. So they still need that personal touch. They need that person to talk to, or they need that paper. Right. So depending on the disease states, you have to diversify how you approach those patients. It's not a one size fits all. But the enhancement is, as the population is aging and people are starting to get older, as you can tell from Bob and I, from the gray hair or lack of hair, that we are digitally savvy, and our friends and our family members are coming of that age where things start to go wrong. But we're of that digital age.
Yeah.
And my point is, the best opportunity to get patients on drug the quickest and to keep them on is personalizing it to whatever they feel comfortable with. Digital is the least expensive to get patients the information they need, but offering them the opportunity to talk to a live person or to receive information through the mail or further digital materials. That's what's the enhancement. That's what's making, I believe, companies successful. And the vendors that we're using, the smart ones and the ones that are doing it well, are employing all those. But the base of it is the digital outreach as the first part, because it's the least expensive and the most amount of people can be reached with it.
Yeah. So, Jason, that's a very good point. And in Canada, we are trying to get there in terms of digitization. Working with proxy metrics, open rates, click rates, measuring patient engagements as a result, and adherence reminders and more. So we are getting there, but it's been slow. And how much of that, it doesn't come cheap. Of course, there is a certain amount of expense that goes into that. And how much of that is resulting in a quantifiable ROI? That's the most challenging part as of right now, but we will soon get there. It's inevitable.
Well, Raj, I think the challenge is, how do you measure? What do you measure?
Yeah.
And what is the baseline?
Yeah.
And that's why I think digital is so important, because all of the data is there for mining across multiple different aspects, right? So that's where the future is here, and especially with AI, having the opportunity to take digitized content and run it. We're a highly regulated industry. Taking that information, especially with AI, and running it through once, and then putting it out there as many times as you can. That's where the opportunity
scalability is.
Data.
But scalability is possible. I mean, so one of the things we do, one of the projects we're working on is to educate patients through their mobile on video. And it's the doctor's content on video. I've talked about this a few times, but one of the advantages of that is that you get real-time feedback, real-time intelligence. So whether or not the patient walks into the clinic, doctor says, I'm going to enroll you. The patient scans a QR code and self-enrolls, name, email, phone, that's it. And immediately they get a text with a video. And it's the doctor explaining, or a KOL, whether it's a clone, AI clone, or the real doctor or the KOL, but it's some sort of video explaining the condition. And the patient then watches it, and that real-time watch time goes into the dashboard on the back end. So the brand owner, the manager, the PSP manager can see, they can see the map of Canada, a map of the US, and see all these videos being watched all over the country, and then what's the watch time. Now you can also tell seasonally. I mean, there are brands that are seasonal in nature, where we see asthma products a certain way, right? They're seasonal. So they can see, okay, let me change out the content based on watch time. And you can do it in real time.
Yeah.
So that's why I think there's a lot of customization opportunities, is to really, really know the patient, figure out what works. And yes, you're right, EMRs are super important for enrollment, because we're relying on the doctor. But increasingly, I think as we also shift, and you've seen this, Rajeswari, have you seen this direct to patient with the GLP-1s?
Yeah, absolutely.
Does a doctor matter? I mean, yes, of course, doctors matter. Of course, we're all in the doctor business. Healthcare would not be run without doctors. But but the question becomes is what is, as you said it yourself, the role of patient empowerment is to meet the patient,
Yeah.
not the brand owner or the doctor. So as you think about this, Rajeswari, how do you view what's worked? Let's go into now what's working in some programs. Give us an example of what's worked in terms of maybe some programs that you've seen. What are the other characteristics of what makes a program successful?
Sure. So the one thing that we want to get out of the way is uploading in all EMRs, right, across Canada instead of having this phased approach, because you lose momentum.
Yeah.
The momentum you don't want to lose. You get one shot at enrollment at launch during a product. I mean, at the beginning of the product launch, you take that shot and you bend it like Beckham. That's my only advice over there. You don't have time. You don't have the luxury to have a phased sort of situation there.
Yeah.
So all at once, all EMRs right at launch. That's the way to go. You want to get that out of the way. You don't want that barrier. The second most important challenge that we've seen that gets in the way of the uptake of patient support programs is the eligibility criteria. Now, eligibility criteria, some programs most programs have the eligibility criteria because you don't want to be on the hook for the patient in case they don't get commercialized. Right. We have a stringent eligibility criteria. You can categorize them into three. One is the severity of the disease and the duration of the disease. That's number one. Number two is the prior therapies taken and their ineffectiveness as a result, duration there too. The third is the current quality of life. And how it is suboptimal, and this medication is supposed to help the patient. So payers have these eligibility criteria so that they ensure that the medication is reaching the patient who needs it the most. But those eligibility criteria also happen to be barriers that stand in the way of patients getting enrolled into the program, because only when the patient meets those eligibility criteria, they're able to complete the enrollment. Right? And that is one of the ways that the program modulates and ensures that this patient will be commercialized by the payers.
Yeah. Yeah.
Right?
What are which therapeutic area do you think that impacts the most?
Immunology, because especially dermatology, because the derms are so sensitive and it's a very, very saturated and a competitive market. So this is a top focus for many companies, immunology, dermatology, and rheumatology, and it's a very, very competitive space. So here, if you go with this phased launch in the EMRs, you're going to fail miserably. So coming back to the eligibility criteria and taking them down, what one company did was initiate a quick start offering. Now, this offering basically said that as long as the patient is on label, they will get medication, and we, at our end, we will try our best to commercialize this patient. If by any chance this patient does not get commercialized, we will still provide them free medication to no end.
Wow, that's a big, bold move.
Very bold move, very bold and one of a kind. And another competitor also started doing that. They also had success. So this initiative resulted in a 20% lift in annual sales. But this is not without its caveats. There are other systemic issues that are caused by this particular offering. For once, basically, the patient being on label, that is fine. That's the only criteria. But the patient may not meet the other criteria that the payers ask for, and you may never be able to commercialize them. So you're on hook for those patients.
Wow. That's a big bet. I mean, I guess the thing is, like in your view, is that you're launching once and it's a very competitive market. So you might as well take the hit in terms of paying for some of these patients that may not be covered, and just take it as a marketing expense and just get it out in the market as soon as possible.
Yeah, this was actually introduced later in the life cycle. So all programs have a life cycle. So it wasn't introduced at launch. It was introduced somewhere in the middle of the program life cycle, the product life cycle, because of the most competitive landscape, the situation, and considering all the previous factors in mind that happened post-launch. So when this offering is introduced, and if you choose to go that way, expect a mass influx of patients because you open the floodgates.
Yes.
And at your vendor end, you need to have the infrastructure capabilities that can handle that mass upscaling to receive that many patients. You're looking at supply distribution issues. You're looking at increased hub operations. You may have to double, triple your workforce. And that's a lot you will see in headcount. Don't be surprised if 80% of your invoice amounts are because of headcounts. So that's a lot. And just to give a brief example, say we introduce Quick Start the beginning of the month. Just take an example. You have an influx of 1,000 patients, right? 30% or 300 of those patients you couldn't commercialize. Just as an example. So just looking at very basic costs, and this is a very deflated amount, just consider the dispensing fees, courier fees. Say it's a flat $100 per patient, right? 300 times 100, you're looking at $30,000.
Yeah.
This is every month and this is just in the maintenance mode.
Wow.
So you're shipping once a month, you're incurring that $30,000 cost. And towards the end of the year, you have a $360,000 cost just for those 300 patients.
Yeah.
Now, patients keep coming. That number is going to keep increasing. You can never end this.
Yeah.
And
Wow.
by the end of 3 years, what is your expense like? And this is a very deflated amount. This is just the dispensing fee and the shipping fee.
Yeah.
We're not taking into account the training fee by the nurse. We're not taking into account the increased frequency of the medication taken in the first few months. We're just taking into account the maintenance part. So that is the level of cost that you will incur. And add to that the cost of the free medication provided to the patients. That's hitting your P&L. These expenses are hitting your program budget. The cost of the free medication itself is hitting your P&L.
Wow. That's incredible. That's incredible. That's a really difficult scenario here.
Very. Right? So you may get a lift of 20% in the annual sales. But all of these aspects, all of this,
you're not going to make any profit. There's no profit margin. There's no margin.
The gross to net.
Yeah. What's that?
The gross to net is severely
so that's severely impacted. And additionally, you need to look at the portfolio as a whole. You have other assets in the pipeline that you are going to launch. So now if you think that the physician is going to, out of goodwill, emanate some sort of a halo effect onto your other products, you are wrong. This has more of a domino effect. They said, you're the same company, you offered Quick Start for this particular product, now offer it for other products too. And at this point, very early in the life cycle.
Yeah.
So there you go. So you need to anticipate there needs to be a certain degree of fearlessness in leadership. If you want to introduce,
well, you got to get approval from this. You should be best friends with the CFO, basically. Be like, hey, you need to give me some time to recover this cost here. And overall, depends on the goal. Sometimes, public companies need to hit certain metrics and goals, and private companies alike. So I think it's a good point that it's a Quick Start can be really, you can be bold, but really difficult to recover sometimes, depending on how many patients sign up and you don't commercialize. So
it reminds me of that story where the person, a guy wins a lottery, right? And he gets this prize money, and then he spends it all on his friends, and then ends up in debt.
Yes.
Right. So before you buy that ticket, you make sure you know what to do with the prize money, because it's an expensive ticket.
Yes, absolutely.
So this is one such scenario.
Yeah, no, I like this. It's a great story. Thank you for sharing that story. Quick Start. That's really powerful. I guess the thing is that, you really have to know how much bandwidth you have internally, do some really good forecasting. And then see if there's a halo effect that can be done for your other brands to really make it worth your while in terms of a strategic, way to bet big, if you will, And then really in competitive markets, they might demand that, right? Like you said, some of these immunology market and dermatology, really competitive for patient services.
Yeah, but not everything is doom and gloom. You always have the real world evidence from these initiatives that help with peer negotiations, outcomes based agreement for the next assets, down.
Yeah.
Not everything is doom and gloom, but it depends on you, how you use the revenue, the data, the learnings that you get from one such initiative, how you use it for your future products and your portfolio.
Yeah, that's beautiful. I like that. Jason, walk us through, if you don't mind, some of the things, one thing that you've seen that works really well in an effective patient services program, in a competitive market. What have you seen that works really well? Is there a core theme that you're seeing in the marketplace that's more kind of sort of simpler, less bigger of a bet, but more like, okay, I know this is going to work? What's your sense of that?
Right. So having or currently running patient operations for a personalized medicine product, there's different aspects of it. There's getting the patient on, which includes going through the benefits investigation, getting the clinician to actually order it, getting them scheduled, getting the drug put into the patient's own cells, and getting it back to them in a certain amount of time before those live cells aren't effective anymore and back into them. It's a complicated process.
Yes.
Versus the more of the mainstream. I just need to get a script. I need to get the patient on the product as quick as possible, and I need to get them on that product and keep them on it. Right? Personalized medicine, that's the way we're going in a lot of the ologies, the oncology, immunology, neurology. So when you think about the extra information that has to be gathered and the complications or the complicated therapies, how they're working on a cellular level, it's a little different opportunity for companies to partner with HCPs, with doctors, to educate their patients on why do they need this therapy versus a pill where they could just take it.
Yeah.
What are the benefits? What are the risks? What are the financial aspects? And how are they or their caregivers going to help them through the process?
Yeah.
So what I've seen work best is that hand-holding, right? That it's not just about personalized medicine, it's about the personalized journey. And where companies are succeeding is helping physicians to educate. Let's face it, doctors have 10 to 15 minutes to deliver bad news, try to help the patients understand where they are in the process and what's the right opportunity for them to take products. And we talked about the evolution. The evolution is how do pharma partner with those HCPs to make their lives easier. It doesn't replace why the doctor is using that drug or that product. It's enhancing their conversation where 75% of the physicians are not used to talking to patients. They're used to talking on a technical level. We've heard the term bedside manner.
Yes.
A lot of them don't have it.
No.
So if pharma can partner and make the physicians' lives a little easier, make the patients a little less apprehensive, that's what's the enhancement, and that's where I think the industry is going.
Yeah. I think it's a really good point. I have a story to share. We worked with a doctored a number of clinics, ketamine clinics. Okay, and he was having trouble with patients not signing up for ketamine therapy for depression, anxiety, mental health conditions. And working with them for a few, for a little while, I came to the realization that because he had just started these clinics, and he was in a different state, and he moved to different states. And long story, but he was an anesthesiologist. And then it hit me: anesthesiologists are not used to talking to people. They're asleep. They put him to sleep.
Yeah.
So, his bedside manner was terrible. He didn't want to spend time educating patients.
No.
And when they're on a 6-course, IV drip of ketamine, a product that, is controversial in some sense, right? With Matthew Perry, so there's a lot of education that was needed.
Yeah.
And, our suggestion to him was, listen, you need to slow down, you need to record some videos, send it to them before they come and after they leave. And then, take a little time to educate these patients. And he's like, oh, I'm like, dude, you're a doctor running multiple clinics. You've got to spend time educating them. And his nature as an anesthesiologist, he never learned that. He never had to that. His most conversation he did was count to 5 backwards. And the patient would go 5, 4, 3 and sleep. And so this is a very important point, is that we have to really think at that doctor level. We keep going back to from an enrollment that Rajeswari talked about. And then what you talked about, Jason, is this evolution of, how do we get doctors involved in this journey? Let's talk now about, let's shift gears a little bit, Rajeswari. So let's talk about one of the things that you talk about is field force involvement in successful patient services program. So let's now, in this segment, let's really focus on field force and how do you get the field force involved? Why get the field force involved? Rajeswari, tell us.
Absolutely. So, Bob, the field force basically are the lifeblood of the organization. They are the closest to the customer, and they are the one making the value proposition for both your brand as well as your PSP. Now, PSP, the program is basically helping the brand realize its value by helping the patients achieving those outcomes. That's what the programs do. They enable the patients to achieve those clinical outcomes. It's an enabler of the product itself. Now, how it is currently being marketed is that, here's a free drug program. Here is your, assistance. It's a PAP. Instead of patient support, it's not a PAP for a reason. It's not patient assistance for a reason. So improper messaging is one of the key issues, standing in the way of the holistic uptake that a patient support program is supposed to have. It's the clinical training offered, the digital materials offered, the apps, the QR codes on the enrollment form, the financial assistance, of course, that's marketed again incorrectly as well. There's so many other holistic, services offered by the patient support program. So understanding the full scope of the offerings and their limitations, that's severely lacking, and that's what stands in the way of the proper utilization of the patient support. Now, it's very easy to blame the reps, but I tell you what's happening. That's causing this commoditized messaging. So we call this a commoditized messaging, unfortunately, and not a value proposition. So what's causing this is really lack of training. They're not empowered with proper training about the PSP. What is a PSP? What is a patient support program? It's a set of offerings, a holistic set of offerings that is supposed to provide the patient the maximum value to help them achieve those patient outcomes, the clinical outcomes. That's essentially the value messaging. And now reps need to be trained as to why a program is designed a certain way versus others. Some programs have a quick start offering. others don't? Why are they designed a certain way? Oncology programs are designed very differently from immunology programs, and I have experience in both. And they have very different value propositions. And why are they designed that way? So the rationale behind that design is very important, training the reps on that, training the reps on the full scope of the program's offering. There are proactive and reactive services. Now, proactive services, let's take, for example, the financial services. The proactive financial offerings are the copay, the 20% flat. Right? There are reactive offerings as well, such as the deductible support. The reactive offerings are not to be marketed by the reps, but having knowledge of that and the limitations of that is very important. Now, for example, the reactive offering is deductible support for certain public providers, payers, certain public payers. It's a reactive offering, as in only if the patient calls the patient support and says, hey, I don't think I can afford my deductible this year.
Yeah.
So I don't think I can stay on the medication because, I have to pay the deductible in order to get my next dose. So I'm sorry, I may not be able to continue. So in that case, the program steps in. So that's a reactive offering. So here, basically, deductible support is offered to patients with a certain income criteria. So say, for example, in Ontario, the provincial payer basically would charge a deductible of 4% of your net household income. So if your net household income is, say, $100,000, you have an out-of-pocket expense of $4,000. And if you're unable to pay that, and say you're not able to continue therapy as a reason, then the program would step in and provide. But again, this is to ensure that only those financially vulnerable, most vulnerable, get the support. So a doctor might get a patient complaining, hey, I actually asked for deductible support and they didn't give it to me. Why? Because your net household income was close to $1 million. So you're not exactly financially vulnerable. Have other patients, maybe a single mother with 3 children, and her net household income is $80,000. She's not able to pay the deductible, so the program helped her. So here, the physician actually complains to the rep, saying that, you know what, because my patient complained, I'm not going to prescribe your product anymore. Just don't even come visit me anymore. But this is an actual conversation.
Wow.
And the rep just stands there. It's a very awkward situation. Because they didn't even know about this deductible reactive offering. All they're doing is selling the 20% flat, the copay, because that's the only thing they know. They haven't been educated. So the rep needs to be trained to handle these sort of situations. And for that, they need to know the limitations, the scope of the offering, the limitations of that. So if they were able to stand to the physician and say, you know what, they're not exactly financially vulnerable. That's why they got rejected.
So would they know that though, Rajeswari? I mean, I guess the thing is the company would inform the rep. I mean, I guess, I don't know. Like, again, in that case, okay, let's suppose the rep was trained, okay, and got it. Would they get the information on that particular patient from the patient services, program managers or the hub, right?
De-identified, yes. De-identified information they would get from...
They'll get a report.
And there's a time lag, right? They get out of the doctor's office. They're unable to manage that situation.
Yes.
Program's perception gets impacted.
Yes.
Brand performance get impacted. For the next 1 week, the doctor will not prescribe. So you see, not being able to handle that objection on your feet because you didn't have the data points. You didn't have the knowledge that this was an offering in the first place.
Yes.
At least if you're able to say that, there is a limitation like this, let me just ensure that this patient wasn't just, mishandled. In this situation.
Of course.
It's very likely they're not. But just so you know, this is the situation that they may not be financially vulnerable. That's why they didn't get the offering, but the other patient did. So to be able to handle that. One other example, the physician might say, hey, my patient wanted to go on a long vacation to Costa Rica, And because he's taking your medication every month, he's unable to leave the country. Fun fact, this is a reactive offering. Again, we actually offer vacation supply for a certain duration of time. The patient needs to
Yeah,
call the patient
that's
support
smart.
program
Yeah.
and then ask. The only caveat here is that if they damage the medication or if they lose the medication, it will not be replaced.
Mhm.
But there is a certain amount that is dispensed for them to
Wow.
take to wherever they go for a couple of months,
Mhm.
snowbirds especially, and they can come back. So these are the sort of conversations that rep need the data points to be able to handle that with the physician. Instead, they're getting destroyed in physicians' offices.
Yes.
They're unable to defend the PSP, they're unable to defend the program. It impacts your program performance, your brand performance, and
And limit your access. And forget it. Your
uh,
access is limited. Yeah. If you screw it up, it's done. You're not
exactly.
welcome back in the office for any new data. I mean, you can go to ASCO all you want and have great new data to present. But
Yeah.
then if your access is limited to the doctor's office because of poor communications between the rep and the doctor, forget it. It's over.
Yeah, and that's because of lack of training. And you hit that nail on the head. We need that training because reps are actually access consultants.
Yes.
They're access and value consultants, not just your reps.
Yeah.
So having that training is very important. And to be able to deal with that situation, it comes from competence. And the competence comes from empowerment through training.
Yeah.
Free backpacks and water bottles don't do this.
No, they don't. And I think you've raised a very important point. And Jason, Jason and I talked about this recently about how the evolution of the field force, and you brought it up really well. Thank you, Rajeswari, for bringing this up as a success tool, a success asset. Are the field force. A part of it is not just because they should be trained, but in fact, to begin with, there's a brand we were talking about recently. It's a specialty brand, oncology. They're like third or fourth, in the market. It's a specialty product, effective, works really well, has good data, but the reps can't get in. And so how do you get into institutions? Today, oncology, I mean, yes, of course, there's a lot of, community oncologists, hematologists, but so many are in institutions, medical service organizations, health systems. And so that conversation there is not about information. It's not about, hey, doctor, let me tell you about what the poster presentation was at ASCO that talked about our drug in this specific patient population. Because the doctor is not going to see you.
Yeah.
They want to know in their institution how you're going to help them with bigger problems, right?
Yeah.
This is the and it's not just a matter of let's train the reps, let's get the reps to ask for better patient services programs so that we can get access to doctors and to institutions where we can't even set in the door. I had somebody I was speaking to at a specialty pharma company, and she said these organizations they don't share any data with the pharma company. They don't tell them the usage. They don't tell them anything. They just buy, and then they just buy and say, that's it. It's a transactional relationship. So there's no optics and intelligence of how the patients are actually utilizing the product, which is really bad. And so the partner relationship, the partnering program, is the way to get access from a field force or key account managers. Jason, what's your thought on that in terms of key account managers, and Rajesh, where he's talking about rep training and how do you get the sales? So what is your view on field force engagement in patient support programs?
Wow, that's a whole nother such session in itself, Bob.
Yeah.
So
Yeah.
key account management is now evolving to a customer engagement ecosystem. It's not just about the salesperson, and that's what key account management really focuses on. If you think about our customers, they're becoming more and more sophisticated by data, by therapy. They're purchasing more and more practices and specialties, or combining specialties into single operations. So when you think about all of the different pieces of, let's say, an ownership, you have an HCP who goes to an address, an office, and that office is owned by some sort of network or hospital, you don't know where the influence is. You don't know where the decision makers are. Is it clinical? Is it financial? So if you've seen one organization, you've seen one organization. And it's the CAM can't do it all themselves. So again, think about, you got pharmacy, you have the physician, you have practice management, you have allied health professionals, you have finance, you have IT, all of those different, I can go on and on, all of those different customers are pieces of the puzzle.
Yeah.
And if you think about what are the pharma companies' opportunities to put those pieces together, you have the CAM, which is sales, you have market access for your field reimbursement people, you have your medical science liaisons, you have your nurse educators. There's 4 or 5, you have patient operations or patient support.
Yeah.
You have marketing, you have commercial operations. All of those have to work together. All those people have to work together. But in the same respect, you have to be able to organize them. And that's where the CAM comes in.
Yeah.
Their job is to organize the conversations, make sure that they're moving all of those inputs to help a non-user become a user. And along that patient journey, there's the customer journey, and they're going together. So it's a big dance that has to be coordinated, and there's inconsistency from customer to customer. So that's why I'm saying it's now a customer engagement ecosystem. It's not just about key account management.
Yeah.
And speaking of inconsistency there, Bob, as we chatted, how patient services, the provision of it is going to be democratized. So different parties are going to be providing the same services with different quality and efficiency. And guess where all of this feedback is going to go? It's going to go to the physician from the patients, and they're all going to hit your reps.
Yeah.
So it's going to get a lot worse. And this training is going to be critical for the evolution of everyone, of the entire landscape, that the reps are trained.
Yes. Yeah. Yes. They're the front line. And if they don't have the knowledge, what to say, how to say it, the connections and the data to know what's going on in that practice, it's terrible. It's really, it just shows poor management from the company level. And that speaks volumes, as you said, Rajeswari, about your brand promise. So I think that, so this is very powerful as a field force employment and deployment and training, getting that right. I think it's key. Let's zoom out and wrap up here a little bit. Now we've shared a lot of really great stories and examples. Give me, if you will, your view, your advice. Okay, Jason, I'm going to start with you first, and then we'll go to Rajeswari, and I'm going to give you some advice as well. But I'd love some advice for patient services leaders who are working in specialty pharma, who are working to launch a new product this year. As they're working to launch a new product or revive a stagnant brand. Okay, Jason, what's your advice to a patient services leader right now? What is the one thing or two things that you think, hey, this is what I think you ought to do because I learned it the hard way and I'm offering it to you. So tell us.
So my advice is to be open to new opportunities and don't keep doing the same thing over and over again. The environment is scalable due to technology and AI, and let's work smarter, not harder.
Love it. Great. Thank you for that. Rajeswari, what about you? What's your advice to patient services? Yes, tell us.
Same here. Work smarter, not harder. Be open to new innovative initiatives like self-reimbursement, where the patient self-navigates themselves across the reimbursement landscape. Empower people more. Empower your reps. Empower your program managers to be able to deal with the current landscape. It's fairly complex. it's ambiguous, it's volatile. So empowerment and innovation are the two key pillars I would advise.
I appreciate that. That's wonderful. I love that. Peter Drucker, who was a famous management marketing guru back in the 60s, wrote a beautiful, beautiful piece in the Harvard Business Review. And he said there's two success strategies in business. Two success. You know what they are? Innovation and marketing. Innovation and marketing. That's it. And both of you talked about that. So I'm going to close and say my piece of advice is take action. Don't just listen to webinars like this. Don't just go to, the Las Vegas, Assembia, or go to, New York for these meetings and conferences, sit in the room and say nice things. When you go back to the office, remote or in person, okay, do something different. You've got to take action. I can tell you one thing I learned over my career at Pfizer for 25 years, 23 years, and so on, is that the ones who do not take action, you never like it because you're like, you kind of like dislike your job because you're being restricted for doing a lot of things. But then, you find yourself on the other side, hopefully not, of a reorg. And so those who innovate are the ones who really grow and progress in their careers. So I encourage you to progress in your careers. This has been a very valuable conversation for me. Rajeswari, thank you so much. Jason, I hope you found it also useful. Where can we reach you, Rajeswari, if we want? I guess here on LinkedIn, right?
Yes, absolutely.
Wonderful, wonderful. And if you don't mind, I'd love for you to maybe put together like a one-pager of your ideas that you have. I'm happy to share it on the LinkedIn post or attach it to this. But just sort of your advice for patient service leaders. Love to write about it and talk about it on a LinkedIn post or some other way, in some way, shape, or form. So, thank you for coming in and sharing your valuable advice, Rajeswari.
Thank you for including me. Thank you so much, Bob.
Thank you. Thank you, Jason. Thank you very much, of course.
Appreciate it, Bob.
Thank you. Well, I hope you all had a great time. Patient services leaders, brand managers, commercial executives. My name is Bob Miglani for the Patient Experience Podcast. Thank you and have a great rest of the day. Take care. Bye now. Bye, everybody.